So first of all, I'd like to thank the organizers for giving me this opportunity to share two interesting cases today. So this is my disclosure, and my objective is to briefly present two interesting, important case differentials for psoriasis. So this is the 5% that Dr. Bruce mentioned earlier. So case one is a case of a 25-year-old Filipino male who had a 6-month history of pruritic erythematous scaly plaques on scalp and face with noted progressive nail changes and reported arthralgia. He also had unintentional weight loss, but with no known comorbidities, no family history of psoriasis, no vices, and denied having multiple sexual partners. So these are the lesions of the patient on examination. There were multiple erythematous well-defined plaques with adherent scales on the scalp, extending beyond the hairline, and as well as in the seborrheic areas of the face in front, as well as in the sides. And there were noted significant nail changes that can be seen in psoriasis. So given the presentation of this patient, the initial impression at the time was psoriasis involving the scalp, nails, and the possibility of psoriatic arthritis. Fungal infection was ruled out with a negative KOH smear of the skin and nails, and PAS stain of the nail plate was also negative. So while the patient with the diagnosis was given topical steroids, and he was referred to rheumatology. But on follow-up, despite the topical steroid treatment, there was no improvement of the lesions, hence the biopsy was done. So on biopsy, it showed psoriasiform epidermal hyperplasia with lichenoid infiltrates of lymphocytes, histiocytes, and plasma cells, giving the diagnosis of syphilis. Nail biopsy also did not show psoriasis, and the further laboratory tests were done to look for other STIs, and these are the following reactive results. So this case is a case of a secondary syphilis in an immunocompromised patient with hepatitis B and C and HIV. So treatment was initiated. He was given benzathine penicillin, and antiretrovirals was started, and prophylaxis. So this is the patient 1 month after benzathine penicillin was given, with the complete resolution of the lesions on the face, as well as marked improvement of the lesions, syphilitic lesions on the nails. So the second case is a case of a 15-year-old female who had a 7-month history of erythematous, pruritic, thick scaly papules and plaques on the face, on the trunk, on the extremities, and genital area. She also had yellowish discoloration and hyperkeratosis of the nails. She also reported joint pains, and there was intermittent fever and easy fatigability. So on examination, these are the lesions of the patient. She had well-defined erythematous papules and plaques. Some were conical and hyperkeratotic with adherent scales located on the face and on the nape and the upper back, as shown in these photos. There were also lesions on the trunk and arms noted on the elbow area, on the arms and on the hands involving the palms. And if you can see, there are also significant nail lesions on the fingers. There were also lesions on the lower extremities, as well as a thick lesion on her vulvar area. So the initial impression of this case was psoriasis of rheumatoid type with nail involvement and with the possibility of psoriatic arthritis. But because of the atypical presentation, skin biopsy was done on the first consult, and secondary syphilis was ruled out with the RPR non-reactive result. Baseline laboratory tests were also requested. So the management, while waiting for the result, was topical steroids, and the patient was referred to rheumatology. But despite the steroid treatment, there was progression of the lesions. You can see in these photos involving the entire trunk, as well as worsening of the lesions on the extremities. So biopsy results came back. It showed psoriasis vulgaris on one side, and on the other was interface dermatitis. So that prompted us to do further tests, and DIF showed consistent results with cutaneous lupus erythematosus. So further workup was done, so showing the following results. So she fulfilled the EULAR criteria for systemic LE. And so the final diagnosis for this case was psoriasis, rheumatoid type, and systemic lupus erythematosus overlap. So in summary, I presented two cases that poses diagnostic challenges because they presented with lesions similar to psoriasis involving the skin There were nail involvement and joint pains. However, red flags was recognized, indicating the need for further investigation. So red flags include the atypical presentation of the lesions, poor response to treatment, and presence of other systemic symptoms. So in this case, it was also highlighted the importance of doing a biopsy because it's an invaluable tool in confirming the other differential diagnosis. And in these two cases, we saw that syphilis and lupus erythematosus are two important differential diagnoses for psoriasis, and it's really important to distinguish them to prevent misdiagnosis and improper treatment. Because misdiagnosing syphilis delays antibiotic treatment, and if we give immunosuppressants for psoriasis in a syphilitic patient, that could exacerbate infection. And misdiagnosing systemic lupus erythematosus is critical because systemic involvement often necessitates urgent corticosteroid treatment. So in conclusion, we know that psoriasis, as shown in the earlier lecture, comes in various forms, and we should always consider broader differentials, especially in atypical presentations. And we must understand that psoriasis can coexist with other conditions, and we must respond to red flags. If we see them, if there's poor response to treatment, unusual presentation, that would warrant further investigation. And biopsy as dermatologist is important when you are uncertain and if you want to rule out other diagnoses, because the goal is not just to diagnose psoriasis correctly, but to ensure that we do not miss other differentials or coexisting conditions that may require different therapeutic approaches. So with that, thank you very much for listening.
Thank you very much for those two very, very interesting cases, and it shows the importance of the excellent lecture given by Bruce at the beginning with the wide range of differential diagnosis. So we have to be really careful. Now we're going to switch gears a bit, and I'm happy to introduce Professor Martin Steinhoff, Professor and Chairman of the Department of Dermatology at Hamad Medical Corporation in Qatar. He also serves as the Director of the HMC Translational Research Institute and Associate Residency Program Director. His research interests are neuroimmunology, molecular immunology, precision medicine. Professor Steinhoff has published approximately 300 peer-reviewed articles and contributed to over 40 book chapters and 1,000 abstracts. We are honored to have him with us today. He's going to address the itching and pain of psoriasis.
Thank you so much for the invitation and the very kind introduction. I'm glad to be here. And what we want to see is whether it's really important when we talk about psoriasis. We know in atopic dermatitis, always a big subject, whether it's also important to talk about itch and pain in psoriasis. No conflict of interest for this talk. So there are several publications already demonstrating that itching, as you can see here on the left side, as well as pain, play a role. But the numbers are also varying depending on which population is studied, and also psoriatic arthritis is also included. And on the right side, you can also appreciate that pain is a significant problem for many patients, as well as also itch for more than 50% of the patient, and also from doctor perspective as well as from patient perspective. And also Gil Josipovic and his group, they were studying whether the DLQI is not only correlating in the improvement with the PASI score, but also with the itch score, and could show that also the itch plays a role, at least in some of the patients, for the improvement of the DLQI. So it's really important also to look into that. And there are also anecdotal studies from the last decades, as these two patients, for example, where there was a neuropathy and traumatic nerve palsy, and showing that in these where the nerve palsy was current, that also the psoriasis was asymmetric and different. So whether there is a communication between the immune cells, the vasculature, and the nerves, that was then to be understood. And there were 10 years ago was a study from Harvard showing, at least in the mouse model, that nerves are capable to activate dermal dendritic cells to release IL-23 and to develop in the mouse a psoriasis phenotype. Whether this is a primary effect, secondary effect also, and that can be translated to human disease, of course, still has to be verified or falsified, but at least we have some evidence. There's a cross-communication between immune cells and nerves. And what is important is that this communication is bidirectional. So the nerves can activate receptors on immune cells, aggravating, perpetuating inflammation, and also T cells, as well as dendritic cells, innate lymphoid cells, are capable of activating receptors on sensory nerve endings, perpetuating inflammation, also inducing itch and pain. So let's talk first about pain. Especially clinically, one can see it where there are fissures, and I don't talk here so much about psoriatic arthritis because of the time. But the mechanisms are very similar. So you have activation of C fibers, A delta fibers, then you have peripheral activation, sprouting of nerve fibers, central sensitization, and also the brain plays a role in the perception and also perpetuation of chronic pain. And then you can distinguish based on the nerves which are activated. You can see several subtypes, whether it induces a sharp pain, a dull or burning pain, or also an inflammatory pain. And I want to focus here more on the inflammatory pain because I think that's specific in psoriasis, but also the dull and sharp pain is important because there are different phenotypes. So here you can see this is a busy slide, many receptors on the sensory nerve endings. We all know that antihistamines are not very effective in psoriasis, so histamine receptors don't play a role in itch or in there. And also in pain, we know that there are many receptors. And very interesting is in recent years we have learned that even chemokines and cytokines are capable of activating specific receptors on the nerve endings. And we have shown a couple of years ago that the TNF receptor is also communicating with TRP ion channels, which are very important pain channels, directly to communicate to induce pain. Then there's a second level which we also have to consider when we talk about chronic pain. We all know from posthepatic neuralgia where we need gabapentin or SSRIs to treat this severe pain. And the pain and the itch in the dorsal horn of the spinal cord changes the plasticity during chronic pain. And luckily in psoriasis we don't have these kind of problems as in atopic dermatitis or other diseases, but still we need to consider sometimes that also chronic pain can lead also to the use of medications which are beyond the peripheral treatment, like gabapentin, for example. So let's talk about itch. As you can see here in this post-stroke itching patient, itch can be a very severe symptom which can lead to damage and also psychological and physical stress. So itching should not be underestimated, and often as physicians we underestimate how much patients are suffering from the severe itching, as you can see in these two examples. So it's important to talk about itch, and what we also have learned in recent years, what you can see here in the peripheral nerve, there are many, many receptors. So there's not only histamine receptors, there's also toll-like receptor, proteases, cytokine receptors, prostaglandin receptors, etc., ion channels, which can be activated in this inflammatory soup of a disease, which then activates secondary signaling mechanisms. And then even in the spinal cord level and on the brain, we have several mediators. So we still do not understand fully what is a CTCL itch, what is an atopic dermatitis itch, a psoriasis itch, and how do they differ from each other, and how do they need to be treated differently from each other. But we are getting closer to this. And also important is to mention that these receptors can be also interact with each other. So in psoriasis, we also have the Koebner phenomenon, and we know that scratching can also induce itching. And a couple of years ago, we have looked, for example, in damaged keratinocytes, where we looked at upregulation of the keratinocyte and could show that TLR3 is upregulated, for example, in atopic dermatitis and releases itch mediators such as endothelin and TSLP, which is an important cytokine also in many diseases, and that leads to the nerve activation and itching and scratching. So also we know that scratching can lead to itching and a reactivation of the nerve, and understanding that this is a vicious pathological cycle. So in the periphery, whether it's psoriasis, atopic dermatitis, we now know there are many mediators, not only proteases and peptide, but also cytokines, which then activate the sensory nerve ending, leading to itching or pain, and also releasing then neuropeptides and talking back to the immune cells via neurogenic inflammation, such as a Th17 cell, for example, and aggregating, perpetuating. And also the keratinocyte, like in psoriasis, for example, can release mediators which directly activate high-affinity receptors on the sensory nerve endings. Bernhard Homay and Dr. Zonkoli have studied a couple of years ago and compared psoriasis and atopic dermatitis, and I just want to show you here that we are getting closer also on the PCR level. Each column is one patient, and as you can see here, for example, for IL-31 and IL-31 receptor, that psoriasis had not a lot of release of IL-31, which is the case in atopic dermatitis. So it will be very fascinating in the future, and that hasn't been done for psoriasis, also to study the psoriasis cytokines in order to identify more the itch and pain pathways in psoriasis. Proteases has been shown many publications that it plays a role in psoriasis in many areas, and one of the mechanisms how proteases, which are activated by the keratinocytes, can induce neuroinflammation and itching and pain is also via the PAR2 receptor, which has been cloned about 20 years ago, and it directly activates sensory nerve ending and contributing to itch and pain, but also to neuroinflammation and also release of cytokines such as IL-1, IL-6, etc., IL-8, which are involved in psoriasis. So let's go to the clinic and the therapy, and how can we translate it more into clinical. And this is one of the psoriasis patients which had an itch score of 10 out of 10 and was suffering a lot from this itching more than even of the skin lesion. And the itch was very well controlled using anti-IL-17 therapy, and also indicating that the new medication, anti-IL-17, IL-23, also contribute to the alleviation of itching and even pain, so they are involved. But in which way, whether it's directly or indirectly, is still poorly understood. One study, which we have published a couple of years ago, for example, comparing also etanercept and ixekizumab, definitely has shown that also ixekizumab as an anti-IL-17 therapy has a possibility also to alleviate itching, and even more, the more severe the itching was, also the better anti-IL-17 therapy was working, indicating that IL-17 may be involved. And there's an anti-IL-17 receptor also expressed on DRG neurons, so it could be a direct effect. And supporting this is also from other studies. We know that zicokinumab, for example, also can have a beneficial effect on itching, and this Australian study analysis has shown yet that there are still patients where even if I treat them with anti-psoriasis therapy, anti-TNF, anti-IL-17, that not always the itch reduction correlates with the current biological therapy. So not 100% of the patients can be controlled also with the most modern therapy. So that's why probably we need sometimes additional therapies in the future. There are some medications on the way which may control, such as the trip ion channels, opioid pathways, cannabinoid pathways, and then the cytokine pathways, of course, which we need to understand better, and the proteases which play a role in psoriasis. And last but not least, we also know that many of these cytokines signal through the JAK-STAT pathway, so it could be also that some of the JAK inhibitors which you're using also may contribute to the alleviation of pain and itch in psoriasis, and also to an anti-inflammatory capacity, and also addressing neuroinflammation, what we know in atopic dermatitis, that the JAK inhibitors are also very important by regulating the neuroinflammation component of the disease. So in summary, we can say that, that many of the medication which we are using in psoriasis may address itching and pain pathways, and that also in severe patients, maybe we still need adjunctive and new therapies in order to control this potentially debilitating symptoms in psoriasis. Thank you very much.
Thank you very much, Professor Martin. Maybe we have time for one question, maybe. Does anybody has an urgent question? I know we're short of time, but maybe one. Okay. Yeah.
Joel Gelfand from Philadelphia. It's a very nice talk. One I just want to mention for the audience, the word psoriasis means itch in Greek. That's the origins. Most people don't realize that. Yeah. So itching is a big part of this disease. Do you have patients who you clear the skin and then they still have significant itching? And then how do you address it?
Where they still, the signs are improving, the psoriasis lesion, and still have itching?
Correct.
Yes, it is. Yeah, especially the scalp area, also the groin area. There are still, and especially where I see patients who have more dry skin. And I think that's somehow also related to the keratinocyte. It is not as severe as in non-lesional skin as atopic dermatitis, but still there are some patients, but less. But they are, and I think there is still, and the cytokines are a little bit different, probably because also you see that the skin is then a little bit, it's a little bit more dry, and also they have more scalp involvement.
Do you sometimes add JAK inhibitors or add an IL-31 biologic?
Yes, very good question. Then I often use additional JAK inhibitors, and also upadacitinib have been shown also to work in psoriasis, and that's actually very fast improvement then.
Thank you, Professor Martin. Now we are going to listen to two case presentations. The first one talking about psoriasis symptoms from Romina Contreras, who works as a dermatologist of the Cátedra y Servicio de, I'm going to speak Spanish by the end of this session, de Dermatología del Hospital de Clínicas Paraguay. That's the end of it. Paraguay. And is the president of the Paraguayan Dermatology Society. She's a dermatology, venereology, and internal medicine specialist. She has a special interest in the comprehensive management of psoriasis and comorbidities, combining clinical practice and research. She is an IPC counselor. Thank you, Dr. Romina.
Okay, this is not my presentation. I'm Romina Contreras from Paraguay. This is Joseph. Okay, what a big room. I'm quite nervous, so excuse my English. Thank you very much to the IPC for the invitation. I'm really honored to be here. When Dr. Bruce invited me to present a case, there was this particular patient I had in my mind, and I wanted to discuss the pain in psoriasis. Well, this is a 38-year-old male patient with psoriatic arthritis onset at age 25. 2 years later, he developed cutaneous plaque psoriasis. He's a former smoker. He had no family history of psoriasis. In 2012, he started with inflammatory low back pain. 1 year later, he started with peripheral arthritis of the knees, ankles, hands, and feet, and psoriatic plaque lesions appear on his legs. In 2015, he developed severe left hip pain. He was diagnosed with a vascular necrosis, likely related to a history of self-medicated oral steroids. In my country, patients can buy cortical steroids without any prescription. Rheumatologists started methotrexate, but this medication was very poorly tolerated by the patient. In 2020, infliximab was started, and this resulted in joint improvement, but only with partial skin clearance. This was the patient. He was on infliximab for 3 years with irregular administration. He developed later a secondary failure. In March of 2023, he started ustekinumab 45 milligrams with only partial skin response, achieving just a PASI 75, probably because he was overweight, but we could not increase the ustekinumab dose. 1 year later, he came back to my office. He was on prednisone 20 milligrams a day for over 6 months in order to relieve the pain he was having on his joints. He also he had weight loss, polydipsia, polyuria, and the skin lesions were flared and even more painful. Corticoid-induced diabetes were diagnosed and insulin was started. The plan here was to switch to adalimumab because that was the medication we had available at our service. But quantiferon returned positive. He started chemoprophylaxis for TB for 6 weeks, but he developed psoriasis flare with very widespread lesions in almost all of his body. These lesions were very pruritic and also painful. We started narrowband UVB, and the patient only had a DLQI of 7. By July of 2024, we were able to start adalimumab, and after 3 months, arthritis pain improved